Good evening and welcome to our monthly edition of Journal Club, which is through under the auspices of the Image Group. And today we have with us, as usual, as a part of the program, both a pertinent article that we always discuss as part of this meeting, and also the Eagle Eye competition, where we invite commentaries from our faculty and postgraduates. And so to start today's meeting, today's Journal Club actually highlights one of the topics that we selected for presentation over here, which involves the myeloma, which we all know as an entity, which is 11-14 translocated myeloma, which we always knew as an entity which behaved differently, primarily because the primary disease tends to be rather indolent, but we also know that to gain control over the disease has been a little bit more challenging. And today for us, this journal club actually has selected the article which discusses some of the nuances of the way that this this disease or this entity in myeloma behaves with some of our standard treatments. And to address this journal club, we have our presenter, Dr. Saurabh Dhingra, who is Associate Professor at All India Institute of Medical Sciences, Bhopal, to present the article. And we are also fortunate to have with us Dr. Gayatri Ravi, who is one of the co-authors of this paper, to also discuss the case. So, without much ado, I hand it over to Saurabh to make his presentation on this article.
Hi, good evening, everyone.
Good evening, everyone. Myself, Gaurav Dhingra. I am working as an associate professor at Department of Medical Oncohematology at AIIMS Bhopal. Today, in the Journal Club, we will discuss regarding an article, Distinct Trajectory of Measurable Residual Disease in Transsection 11-14 Myeloma Treated with Quadruplet Therapy. So, to begin with, why translocation 11-14 multiple myeloma a special subset? As we know that it involves the translocation of gene IGH and CCND1 proto-oncogene gene, which leads to increased production of cyclin D1. This generally normal plasma cells and translocation 11-14 negative multiple myeloma depends upon anti-apoptotic protein MCL1 for their survival, while this translocation 11-14 positive myelomas depends upon anti-apoptotic protein BCL2 for their survival, as they have increased BCL2 is to MCL1 and BCL2 is to BCL2L1 ratio. Even this translocation 11-14 positive multiple myelomas have distinct biology with features overlapping with B cells. They have increased expression of CD20 and CD79A. They have decreased expression of CD38 and decreased expression of adhesion molecule CD56. So they present with extramedullary disease and is one of the most common translocations seen in plasma cell leukemias. They even have increased expression of transcription factor PEX5, so they present with lymphoplasmacytic morphology. In the pre-novel agent era, the outcome of translocation 11-14 multiple myeloma was similar and even more favorable than translocation 11-14 negative myeloma. So, the Mayo stratification of myeloma and risk adaptive therapy guidelines classified them as a standard risk myeloma. Even now, they are classified as standard risk as per RISS, R2ISS, and International Myeloma Society, International Myeloma Working Group. Various studies have shown poor response of translocation 11-14 multiple myeloma with proteasome inhibitor. So, in the novel agent era, there are variable outcomes of translocation 11-14 multiple myeloma. In one large cohort study reported by Susan et al., when after excluding cases of high-risk cytogenetics abnormalities, the patients with translocation 11-14 multiple myeloma had an inferior outcome compared to translocation 11-14 negative multiple myeloma. And another large cohort showed no difference in progression-free survival of translocation 11-14 positive multiple myeloma versus translocation 11-14 negative multiple myeloma. In this novel agent era, we evolved from doublet to triplet and now quad therapy, which includes anti-CD38 therapy plus proteasome inhibitor plus IMiDs and steroids. This quadruplet therapy has improved the outcome of newly diagnosed multiple myeloma and has become the preferred first-line therapy in both transplant eligible and transplant ineligible patients. Now, as we moving towards MRD-driven approach for newly diagnosed multiple myeloma, as we know that MRD negativity is associated with prolonged progression-free survival and overall survival, and its early achievement is associated with sustained negativity. In MIDAS trial, irrespective of the patient's baseline cytogenetics, were risk stratified based upon MRD status after 6 cycles of isatuximab KRD regimen. MRD negative patients were randomized to de-intensification with quad consolidation versus autologous stem cell transplant, while MRD positive patients were randomized to intensification with single versus tandem transplant. So the important issue to discuss here is, will translocation 11-14 multiple myeloma, which have a low CD38 expression and poor response to proteasome inhibitor, have similar response as other standard risk group with quad therapy, as some studies have shown lower rates of MRD negativity following quad induction, raising concerns about their long-term outcomes. And in the era of MIDAS trial, will MRD-based treatment be applicable to translocation 11-14 multiple myeloma? So, in this study design, the patients study population included patients from their center with newly diagnosed multiple myeloma treated with quad therapy followed by autologous stem cell transplant, and also the patient from master trial, which was a phase 2 study where patients after achieving quad therapy with DARA KRD plus autologous stem cell transplant were further concentrated based upon further concentrated and received maintenance therapy if they were MRD positive at the level of 10 to the minus 5. While in milestone study, the trial, which was a phase 2 trial, in which patients after DARA VRD induction, if they achieved MRD negative, then the options of autologous transplant was deferred. So FISH in this study was done by enrichment with CD138 plasma cells and was FISH was used for determining translocation 11-14 and the cytogenetic abnormality after CD138 plasma cell enrichment. Patients were grouped into translocation 11-14 positive and negative group. MRD assessment was done using first full bone marrow aspirate. MRD was done using NGS clonoSEQ platform, and MRD was reported at 10 to the minus 5 and 10 to the minus 6 level. The statistical analysis included the following tools. Even a predictive model of PFS was made by putting MRD as a time-varying covariate using Cox regression model. The results, the total 302 patients were studied, of which 124 participants were of the clinical trial. Median duration of follow-up was for overall population was 45.8 months, of which 45.3 months was for translocation 11-14 positive patient and 45.8 months for translocation 11-14 negative group. Median age was 65 years in translocation 11-14 positive group, and median age was 62 years in translocation 11-14 negative group, which was comparable. According to ISS staging, there was a comparable population in both the group. Deletion 17 was positive patients were more in translocation 11-14 negative group, that is 18% compared to 9% in translocation 11-14 positive group. Patients with more than one high-risk cytogenetic abnormalities were more commonly seen in translocation 11-14 negative myeloma group. Coming to post-transplant therapy, therapy was stopped in 24% of the patients in translocation 11-14 negative group, as probably more number of patients achieved MRD negative status, and maintenance therapy was used more in translocation 11-14 positive group. So MRD guided cessation of therapy was seen more in translocation 11-14 negative group versus translocation 11-14 positive group, 45% versus 36%. When we studied MRD negativity in translocation 11-14 positive versus negative group, post-induction at 10 to the power minus 5 level, just 9% patients achieved MRD negativity in translocation 11-14 positive group, while the 31% patients achieved MRD negativity in translocation 11-14 negative group, which was significantly different. Similar pictures was also seen at 10 to the power minus 6 level. Even post-autologous stem cell transplant and any time after the transplant, the MRD negative rate of translocation 11-14 negative group was significantly better than the translocation 11-14 positive group. Important thing to observe is that MRD negative status improved with rate improved with each line of therapy in both the groups, and there was no difference in sustained MRD negativity rate in both the groups at the level of both 10 to the power minus 5 and 10 to the power minus 6. If we see the graph for median time to achieve MRD negative, it was shorter in translocation 11-14 negative myeloma than translocation 11-14 positive myeloma. The median time to achieve MRD negative at the power of 10 to the minus 5 was 13.6 months in translocation 11-14 negative 11-14 positive multiple myeloma versus 7.7 months in 10 to translocation 11-14 negative myelomas. Even at 10 to the power minus 6 level, the median time was not reached for translocation 11-14 positive myeloma versus 11.1 month was seen for translocation 11-14 negative myelomas. If we talk about progression-free survival, it was significantly better for translocation 11-14 positive myeloma compared to translocation 11-14 negative multiple myeloma, maybe because more patients of deletion 17 were in translocation 11-14 negative myeloma group. So the PFS rate at 4 years were 90% for translocation 11-14 positive myeloma, while 72% for translocation 11-14 negative myeloma. Even when the high-risk cytogenetic abnormality patients were excluded, the PFS of translocation 11-14 positive myelomas was better, but not clinically significant. And the 4-year PFS was 95% versus 84% for the translocation 11-14 versus negative patient. On multivariate analysis, the ISS staging and presence of high-risk cytogenetic abnormalities were associated with poor progression-free survival, while sustained MRD negativity rates and presence of translocation 11-14 were associated with reduced risk of progression or death. Now coming to discussion part, for patients with translocation 11-14 positive myelomas, patients, as we have seen, the patients is the key role, as they have slow and steady improvement in the response after each phase of cycle. MRD negative rates in translocation 11-14 myeloma post-induction was just 9%, which improved to 36% after autologous stem cell transplant. So transplant plays a very important role in improving the depth of response in translocation 11-14 multiple myeloma. In phase 3 MIDAS trial study, also the patient with translocation 11-14 multiple myeloma had a lower rate of MRD negativity after induction. MRD at the power of 10 to the minus 5 was 40% in translocation 11-14 positive patient versus 71% for the translocation 11-14 negative group. Also, MRD at the power of 10 to the minus 5 in translocation 11-14 positive patient in our study was 9% versus 40% in MIDAS trial, probably because the number of induction cycles in our studies was 4 before assessment of MRD, while they used 6 cycles after which MRD assessment was done. And also they used carfilzomib in their trial, while 63% of the patients in our trial received bortezomib. So achievement of early MRD negativity is associated with longer progression-free survival, but translocation 1114 positive patient are associated with slower and gradual response to therapy, and even achieve sustained MRD negativity equivalent to translocation 1114 negative myeloma. So translocation 1114 myeloma, even though have low rate of MRD negativity post-induction, but achieves better PFS with further treatment. So the sustained MRD negativity is emerging as an important predictor of progression-free survival, which was also highlighted in this study, where sustained MRD negativity was achieved by a translocation 1114 patient comparable to translocation 1114 negative myeloma patient. As we know that translocation 1114 myeloma depends on BCL2 for their survival, so it will be interesting to know that if these proteasome inhibitors are replaced by BCL2 inhibitors at the upfront, will it help in achieving the early MRD negativity? As studies have shown that the BCL2 inhibitors have shown a good response in the relapse refractory setting in patient with translocation 1114 multiple myeloma. The limitations of this study was that there was a heterogeneity in the number of induction cycles and the type of proteasome inhibitor used. This study only included patients who were next generation sequence MRD available, others were excluded. So the data here are conditional depending upon the patient proceeding to autologous stem cell transplant. That is, MRD adaptive post-transplant strategy was used, leading to more intensive treatment for the patient who had persistent MRD. And as we have seen that patients in translocation 1114 positive group had persistent MRD, so they received continued therapy. Maybe probably because of that, they have a better outcome compared to translocation 1114 negative patients. So to conclude, the patients with translocation 1114 myeloma without high-risk cytogenetic abnormalities have a slow trajectory of MRD clearance. Currently, early MRD positive in translocation 1114 myeloma should not be considered at high risk, leading to additional intervention. Presently, autologous stem cell transplant and maintenance therapy forms an important part of translocation 1114 multiple myeloma to improve the MRD negative rates and achieve sustained MRD negativity and improve progression-free survival. Thank you.
Thank you. Thank you, Saurabh, for that excellent presentation and overview. Before I go to Gayatri to discuss a little parts and nuances of the paper and also the limitations that Saurabh discussed in his last few slides. I'd just like to just congratulate you and your team on an excellent paper that actually, in several ways, challenge some of the medical paradigm over here, because we always think that the measurable residual disease is an important predictor. Early responses is an important predictor, which did not turn out to be the case as far as the specific entity 1114 translocated myeloma is concerned. I would also say that the characterization of the disease biology was probably excellent, and in terms of it was a real fantastic kind of strategy to have a dynamic assessment of the MRD at different time points, which actually made the data a lot more cleaner in terms of interpreting what we can as far as the dynamics and the of the 1114 translocated myeloma is concerned. We always knew that these myelomas never went into complete remissions in terms of what we would desire at the level of MRD status. And of course, the sensitivity, the assays, the clonoSEQ assays that you have used, pretty much because of its sensitivity, pretty much actually tells us that what we saw is what we actually have to believe in terms of the dynamics and the trajectory of responses over here. While the numbers are a little low over here, but we cannot expect so in we only see that many 1114 translocated myelomas, isn't it? And but the important thing is that more or less standard treatment it also took it to patients from the clinical trials and also patients who were treated on the standard protocol, which is a acquired regimen over here. But as Ashish had pointed out, it was all patients had compulsorily received autologous stem cell transplant over here, and they were all part of the assessment in terms of the treatment. But having said that, that would be the normal paradigm that we follow for treating all myeloma patients these days, isn't it? So I think to me, one of the things that the validation of the MRD adapted therapy highlights how a prolonged, intensified autologous stem cell transplant treatment also can improve outcomes. And again, we revisit the importance of autologous stem cell transplant over here, irrespective of what the kind of disease might be, in terms of deepening the responses and over there. So an excellent paper, I would say. The data is very clear there for us to see in terms of understanding that it may not be everything at about MRD. We have to persevere with the standard treatments, the standard approaches that we have as far as the treatment of myeloma is concerned still stands good, irrespective of whatever the kind of disease it might be. And also the fact that you should not be too perturbed when you don't have the responses that we desire. And I think that has come out quite well in this paper. So over to you, Gayatri, for your comments. Yeah.
Thank you for your kind words, Dr. Menon. So, I mean, as you rightly said, the quad induction using daratumumab-based regimens have become a standard of care in multiple myeloma, irrespective of cytogenetic risk. The current approach is to start with a quadruplet induction using anti-CD38 antibody, proteasome inhibitor, IMiDs, and steroids. And the number of induction cycles vary depending on the trial, because Griffin used 4 cycles of induction, then transplant, then 2 cycles of consolidation before going into maintenance. Whereas Master used a daratumumab with Kyprolis based induction strategy. So it used 4 cycles of induction, transplant, then 4 cycles of consolidation, then went on to maintenance. But I do have to highlight that the Master was the first study that actually looked at stopping treatment if people were able to achieve sustained MRD negativity. And the definition for sustained MRD negativity has varied since then, because the way Master was done was if you had 2 consecutive MRD negative results at any time point, then that was taken as the sustained MRD negativity, and treatment was subsequently stopped and went on to treatment-free observation. Whereas the current kind of accepted definition in the community for sustained MRD negativity is you have to have a 1-year period in between the 2 MRD measurements before we would call it sustained MRD negative. So, and we also saw in the Griffin trial that the MRD negative rates deepened with time. So post-induction, the MRD negative rates were close to 20-23%. But then if we went on to transplant, that improved the MRD negative rates to close to 60%. So we do see that deepening of response with intensification of therapy moving forward across all cytogenetic groups. But what is important, or what was highlighted more in the study, is the percentage of patients reaching an MRD negative state with the translocation 1114 at every time point was way less compared to people achieving MRD negative state with other standard risk or other cytogenetic features. But just to give an outline of what the trial involved, because this was for the patient selection or the patients included in the trial. For us, we have adapted a standard of care, even in standard of care practice, to do 4 cycles of Dara-VRd induction, followed by autologous stem cell transplant, and then 4 subsequent cycles of consolidation with Dara-VRd, and then go on to maintenance based off of MRD adapted strategy. The Master trial, as I already described, used 4 cycles of induction with Kyprolis-based regimen, and then autologous stem cell transplant, and 4 cycles of Dara-KRd consolidation, and then went on to maintenance. The Milestone trial actually used DARA-VRD induction, but used it for 6 cycles. So even between the master trial and the Milestone trial, there was a difference in number of cycles of induction. So the Milestone used 4 cycles of DARA-VRD induction, followed by MRD assessment at the end of induction. And then this did not look for differing transplant. The master did not look for differing transplant because everybody went on to transplant and they had to have 2 MRD negative results before the treatment was discontinued. Whereas in Milestone, we looked at differing transplant upfront post-induction. So if post-induction people were MRD negative, the arm A of the Milestone trial would differ, that was MRD negative post-induction, they would defer transplant, go on to additional 3 cycles of consolidation with DARA-VRD. And then if they were MRD positive, as we have seen in other quad trials, the deepening of response happens with ongoing intensification of treatment. So automatically they went into the transplant arm. And of course, there was a transplant deferred arm in patients who were ineligible for transplant for whatever organ functions or performance status. So there was an arm that actually allowed deferring of transplant for ineligibility on the Milestone trial as well. And but again, they went on to get additional 3 cycles of consolidation, like the MRD negative arm. Both the Milestone and the Master looked at treatment-free observation period if people were able to attain sustained MRD negative state. But as I mentioned before, in Milestone, the sustained MRD was defined as 1 year of 2 consecutive MRD negatives before they would go on to a treatment-free observation. It's a small study. It had only 20 patients in the myeloma cohort for the Milestone. Master, of course, was a larger study, a multi-center study. Milestone was a single-center study at UAB. And for us in state of Alabama, we are the only transplant center. So our referrals for transplant comes from all over the state. So even in the standard of care population, there is a difference in the variation of number of induction cycles, depending on if we started treatment here, we stuck to our institutional practice of 4 cycles. But if they're coming from outside, depending on the time of referral, the number of cycles could vary between 4 to 6. So that's where there was a little bit of variability in the patients that were included in the paper. And what we have also seen is that the number of coexisting high-risk cytogenetics is very low in patients who have translocation 1114 compared to translocation 1114 negative population. And I think as Dr. Gaurav had very clearly kind of stressed and outlined, is that even though the percentage of patients achieving MRD negative continue to be low on the translocation 1114 population, once they are achieved MRD negative states, the sustained MRD negativity or ability to hold on to an MRD negative state did not differ based off of presence or absence of 1114 translocation. And what we also saw was a significant improvement in progression-free survival at 4 years, that patients with translocation 1114 had a better outcome, even though they had lower MRD negative rates, had a delayed time or prolonged time in reaching an MRD negative state. They did have improvement in outcomes. And I think that was what was very I would say, the highlight of the paper, because the major concern was looking at, the amount of or the percentage of patients who reached MRD negative state post-induction was pretty low. And I think that kind of raised a concern in terms of, or how the outcomes of these patients are going to be long-term. And I think that was one of the highlights of the paper, I would say, is that, there's no need to panic with having a low MRD negative rates up front, because the ability to achieve MRD negativity improves with time, just like any other myeloma, and the outcomes continue to improve as we treat the patients. And I would stop here for any questions.
Thank you. Thank you, Gayatri, for that beautiful summary of what the trial is all about. And for me, some of the things that pop up is that we still cannot address myeloma with all the parameters as an absolute way to go about it, and that's what your study also showed about. It probably sometimes even probably for only for 11-14, it questions. The interpretation of MRD, early MRD assessment after induction therapy, what we got with other non-11-14 translocation where we had deeper responses. It's a question, as you rightly said, they may be not a need to panic over there in terms of persevering with the standard treatment that you need to go about. So I open it out to discussion. I invite Dr. Velu sir, Dr. Pankaj, Uday, and of course the presenter, Dr. Gaurav Dhingra. Yeah, you have the first opportunity to ask the question. I see your hand raised.
Yeah, thank you. Thank you, Dr. Hari and Dr. Gayatri, for that wonderful, very interesting presentation, and which is not aligned with the long-held view that MRD negativity, like Dr. Hari said, early response and early MRD was always associated with a better PFS and OS. So here comes into play the time points you assess the patient in a longitudinal fashion, which in so many studies is actually not so well documented. At certain point of time, it tells you what you achieve, but longer than that, it's not there, or you have to wait for subsequent results. But here you have shown that actually downstream, things can actually improve. So one of the things I wanted to ask you was, in the non-transplant group, or the transplant ineligible group, I would say, or the deferred group, the two groups that you had, how did they fare in terms of outcomes at the same time points as the ones who underwent an autograft?
So I have to say we don't have the complete data yet because the study is still ongoing for Milestone. So in patients who did achieve MRD negative rates at the end of induction was close to 20%, similar to mimicking the Griffin trial. And we do have patients who have come off treatment with sustained MRD negative rate. I don't have the most recent data, but the one from before, close to, because it was about 20% of patients who achieved MRD negative upfront, and then post-transplant, there was a slight augmentation. So I would say between 20 to 25% of patients did go on treatment-free observation. But of course, this is maybe a year-old data. We haven't run a recent analysis, which will be coming up shortly for the IMS. But that one, we have not seen any progression of disease in the cohort yet. So far, there's not been a documented progression in the myeloma cohort.
Thank you. And my last question is, what were your time points for MRD assessment along longitudinally, number one? And number two, is that like you got one negative, then you waited for how long before you said he or she can go off treatment? Was it 1 year in your study also?
Yeah, so I think that's a very good question. So our time points for MRD assessments were post-induction. That's the first time point for MRD assessment. And then post-transplant, or in transplant deferred group, post 3 cycles of consolidation. And that would be the second time point for MRD assessment. But the sustained MRD negative for both for our standard of practice as well as in the Milestone, we use a 1-year time point. So post consolidation, and then you do a year of maintenance. And if they are MRD negative, then, in standard of care practice, so far, we've been a little cautious because we don't do as much monitoring as on the trial. So for patients with standard risk cytogenetics, we have stopped treatment. But with the caveat that patients would agree to get once a year bone marrow assessment for ongoing MRD assessment. But we have seen MRD resurgence do come back. And on an average, there's about slightly over a year before it comes into a clinical relapse from the time point of MRD resurgence. That's what we are seeing in the kind of the interim analysis we did in our standard of care patients. In Milestone, like I said, the analysis should be shortly done for the recent year, and then we'll know if there was any MRD resurgence. I'm not privy to that data, but we have not had any documented clinical progression on patients we have stopped treatment.
Thank you very much, and I congratulate you on a wonderful study. Thank you very much.
No problem.
Thank you. Uday, I can see, and then Gaurav, and then Sumit. Yeah.
Thank you, sir. Thanks a lot, Dr. Gayatri, for this elaboration. I'm Dr. Uday. So I've got few statistical concerns as far as the paper is concerned. One, you have highlighted again and again that you have two cohorts, bortezomib and carfilzomib-based quad regimens. But I really wonder, why didn't you subject the people to a subgroup analysis based on the PI? That would have given us a better information about carfil versus boti, because we all understand translocation level proteins. Those who are given boti-based regimens, they did not respond very well vis-a-vis Kyprolis-based regimens. That's the first concern. My second concern is you have taken only NGS evaluable patients. That means left out patients with inadequate bone marrow cellularity, non-secretory diseases, low tumor burden. So this all in turn will lead to inflation of the sustained MRD rates. So that could have actually led to a higher sustained MRD rates vis-a-vis it might have been truly so. So that is the second concern. Now, the third concern is the survivor bias. As Velu sir was saying, because you have taken patients who have proceeded to ASCD, there could have been patients who are on, let's take bortezomib-based regimen, standard of care. They would have progressed before the end of induction. So, though this is a small part, but that's a real risk. So, all those patients have got left out. So, actually, when we are analyzing, we are not analyzing the true cohort, but we are analyzing the fallacious cohort of those who could reach up to the transplant or who have been subjected to transplant. So, by these few things, maybe the data could have been slightly different. And also, like when you look at any hazard ratios with a 95% confidence interval, stopping at 0.99. So you again doubt it because you had only 47 patients and your confidence interval varied from 0.13 to 0.99. Huge margin, and you successfully allowed it not to cross 1. So these are few aspects which I thought which should have, because before we take this, because you are telling a very important concept. You are saying like CLL, don't bother about MRD. It's about long-term outcomes which matter, but not early CRD. And also because 1114 has a BCL2 dependency, so they have a lymphoplasmacytic morphology. So your concept, you are driving in that direction, that 1114 myelomas should be taken like CLL, wherein you are not really bothered about MRD at the end of induction. But before we propagate that concept, we need to be really sure that our statistics, the way we have analyzed things, are absolutely perfect. But excellent paper, and it was worth giving it a good read. Thank you.
No, I think it was, I think the questions are pretty relevant. So I may not have got everything in order. So if I missed some answer, please, feel free to let me know that I haven't answered part of your question. So coming to the first one, the total number of patients we included with Kyprolis-based and the Velcade-based regimen, majority of our patients did receive Velcade-based regimen because that was what was standard of care as well as the treatment in the Milestone. So there was a very small proportion of patients who received Kyprolis-based treatment. And as we know, the presence of translocation 1114 was only in about 16% of those patients. So running a subgroup analysis based off of PI, we didn't have enough patients to run that analysis because it's going to be a very, very smaller number to give any statistically significant meaning. But of course, we have our ongoing maintenance of our database. So as time grows, we may end up doing a kind of a future analysis to try to see. But of course, having said that, the Kyprolis-based induction was done as part of the master trial. So that's not, again, a standard of care. that we are implementing in the institute. So we may not be, even with time, not be able to get much patients on the Kyprolis arm and to give that analysis out of a single center study. And your next question was, we included only patients who had gone to transplant and who were MRD evaluable. So of course, we went with clonoSEQ as our way of measuring MRD. So if there was no identifiable sequence, or if they were not MRD evaluable based on had no clonal sequence that could be identified, it is hard to track those patients in terms of MRD response. We could only track them based off of IMWG response. So that again, it was the reason why we did not include patients who were not MRD evaluable. And then this, what else did I miss? I'm sorry, I know I missed another part of that question there.
They had-
So basically, those who are successfully going into transplant and who could not reach transplant.
Yes, so thank you for that. So for us, as a transplant center, we get referrals from all over the state, and there is a percentage of population who decline transplant as well. And at that point, they end up going back to their community partners. So they don't continue to follow in UAB. So there is no tangible way we could follow them to measure kind of longitudinal outcomes. So the attrition rate would have been very high in a non-transplant patients, because post-transplant, we continue to follow them, of course, for the vaccinations and once a year long-term. So we do get our MRD data, which can be in a sustainable pattern. Whereas in non-transplant evaluable patients, they don't show up till they have a relapse and they need a CAR-T, or they need additional treatments or a second opinion for a relapsed myeloma. That's when we see them if they are gone to the community. So it's hard to track and bring them back, because sometimes travel time is 4 hours one way. So they don't really want to come for a clinic visit and just to get a testing done. So that again makes it a very heterogeneous group that would be difficult to interpret in terms of results.
Thank you. Thanks a lot.
Thank you.
And did I miss any of your other questions, Dr. Uday?
No. All answered and all very well explained.
Thank you. And Gaurav, you
Yes,
have.
ma'am.
Yeah.
Good evening, ma'am. Actually, I had two questions. One question has already been answered regarding this your limitation that you have used NGS technique. Another question is that when we see the MRD data, we have seen that every time the MRD status of 1114 negative patients were higher. But when we saw the sustained MRD, we reached the difference was not significant. Was it because they have the 1114 positive had a sustained MRD, or there were high relapse rate in 1114 negative patients?
So I think the way I would interpret that is, once they are able to achieve an MRD negative status, they are able to hold on to it, very similar to people without translocation 1114. So they did not lose their MRD quickly. And I think that's what that point was supposed to convey.
But were there higher rates of relapses in the other group? Because they had deletion 17, higher risk cytogenetic abnormalities. So more of high risk cytogenetic. So they might have relapsed early. But they didn't maintain their MRD, so that's why we achieved an equal MRD state, sustained MRD status.
So, I see what you're saying. No, I think if you're I don't think this paper commented on the progression of people in both the groups. But we do have data of progression from MASTER in people who did stop treatment. And I would say it was at least 50%, but I don't remember the subgroups based off of cytogenetics in that paper. But I can send an email out on that answer. So, but I don't think that that would contribute to having a similar sustained MRD in both in a larger way. But I think what was supposed to be conveyed or understood is you don't lose your MRD response just because you have a translocation 1114. And I think we haven't analyzed the standard of care progression and the milestone, of course, it hasn't been completed yet, so we don't have that data as well. So in terms of progression, the only data that's published and available is from the master trial, but that was a small proportion of patients out of this cohort.
Okay, ma'am. Thank you.
Thank you. Sumit, your question.
Thank you for the excellent discussion. I'll ask two quick questions. First, in this study, wherein the MRD negativity post-induction was 9%, increased to 36% after transplant. Even in the MEDAS, in the 11-14 group, it was 20%, increased to close to 56% post-transplant. So basically, it's a high-dose MEL, which is pushing the MRD negativity instead of 4 or 6 cycles of DARA-based regimen. So for a subset where there is a lower CD38 expression inherently and some relation to BCL lineage also, how much do you believe that a DARA is adding to the treatment? That is my first question. And my second question is, we knew in this study that 11-14s are doing better than non-11-14s. MRD negatives are doing better than non-MRD negatives. Roughly 54% were MRD negative at any time point in 11-14 group, which means half of them. So if you look at only 11-14 group, MRD negative versus positive, what was the incremental value of PFS of achieving MRD negativity in the 11-14 group?
Okay, so coming to your first question, how much does DARA add to the treatment? As you rightly said, there's a low CD38 expression. And that, again, that could contribute to possibly a low initial MRD post-induction to a small extent. But again, we do see that increment with melphalan treatment. So I don't think that should stop us from using a DARA-based regimen up front, because we do know that quad induction definitely does better than a triplet induction for all across board for multiple myeloma. So that would be the first point I would like to stress, that just because there's a low induction, post-induction MRD rates, we should not be stopping using of DARA as an upfront treatment for induction therapy in myeloma, whether based off of translocation 1114 or other high-risk cytogenetics. Coming to the second part of your question, how much sorry, just repeat it one more time so I answered it the right way.
If you look at only 11-14 group, MRD negative versus MRD positive, how much incremental benefits do we have in the PFS if you achieve MRD negativity in 11-14 group?
Oh, I see. For achieving MRD negative and then in that being MRD positive, did it change the PFS? Right. Okay. So I don't think we had that analysis based off of MRD negative to MRD positive in the paper. So I would be hard pressed to comment on that with statistics to say this was the data. It did not look at patients who were MRD negative with PFS of so-and-so or MRD positive with PFS of so-and-so. And part of the reason is because, the number of patients who achieved MRD negative were overall lower. So, that, again, kind of looking at it from the other end, it says that even if we are not able to achieve MRD negative rates in people with translocation 1114, even though they are much lower compared to other population, it did not translate to an adverse outcome in terms of progression-free survival. But I think the percentage of patients who there were only a total of 47 patients who were positive. And in that, you're looking at 9% post-induction. So it's a very, very small data or very, very small number of patients who actually achieved post-induction MRD. So it is going to be a very, it's going to be a limitation in terms of if we ran the PFS, it would give any statistically significant difference. And that's part of the reason why we didn't do that analysis.
Thank you.
Thank you. Thank you for that wonderful discussion. Thank you, Gayatri, and all my colleagues in the group for that wonderful discussion. And I think we have, and thank you, Gayatri. If you wish to be for our remaining part of our meeting, you're welcome to be. We'll be very happy to have you with us for that meeting. And I hand it over to Sumit for the next part of the meeting, which is the Eagle Eye.
Yeah, thank you so much. I really appreciate you guys having me over. And this was a wonderful discussion, kind of forcing through the slicing and dicing of the paper in a very meaningful way. So I really appreciate it. And I would just hang out because I had this hour set for the meetings. I would love to see, how this program runs. So
Yes.
thank you for having me for the prolonged session as well.
Wonderful, 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 wonderful. Yes, please.
Are my slides visible, sir?
Yes.
Yes, sir, you can go ahead, sir.
Yes. Okay. So the Eagle Eye article for this month was Frontline Systemic Treatment Outcomes in POEMS Syndrome, published early this year. So just to review the process for those who are new to this, a recently published article on plasma cell neoplasm is selected. We invite a commentary of 175 words before a deadline. Anyone, irrespective of designation, with an interest can send a commentary. The best commentary is selected by a team of blinded reviewers, and the winner gets a chance to present the journal scan as well as gets a certificate, credit hours, and image lifetime membership. The intent is that the young faculty and students should read the latest articles on plasma cell neoplasms, learn the art of critical appraisal, and at the same time, refine the art of scanning an article. This will lead to more letter to editors and correspondences from our country, and at the same time, get an opportunity to present in front of an august audience. So the 5 factors on which we analyze is first, the word limit, which is very strict, 175 words and not in one word beyond that. Second, the language, the study interpretation, the conclusion, and in today's era, you obviously look for plagiarism or AI generated content in any commentary. Firstly, I would like to thank the reviewers. The competition of Eagle Eye has definitely increased in the last few months, and we need more and more reviewers for the same. I'm grateful to Dr. Hari Menon sir, Dr. Vishwadeep Khoshu, who's from AIIMS Nagpur, Dr. Nikhil Kumar, who's in Rajagiri Hospital, Kochi, and Dr. Saspata Saha, who's in Tata Medical Center, Kolkata. So before I announce the name of the winner, a special mention who was a very close second, and by the term close, I mean it was a tie and it needed a 4th reviewer to break the tie. The close second is Dr. Mehak Trehan. She's currently an associate consultant at Fortis Memorial Research Institute, Gurgaon, India. And the winner for this month is Dr. Amiya Ranjan Nayak. He works as a consultant in the Department of Hematology, DMT and Cellular Therapy at Utkal Hospital, Bhubaneswar. So congratulations, Amiya. I would request neither from my side as team to play the recorded commentary of the journal scan.
Good evening, all. I'm really thankful to the Image Group for giving me this opportunity to present the journal scan article. This is the original paper which was published in British Journal of Hematology by Oliver Tompkins et al. Frontline Systemic Treatment Outcomes in POEMS Syndrome. So POEMS, as we all know, this is a multi-system plasma cell disorder, and VEGF is the central biomarker. A transplant, autologous transplant, is considered standard in the fit patients, but the role of induction and the non-transplant strategies are not very clear. Authors have tried to evaluate the outcomes of frontline systemic therapy in POEMS, transplant versus non-transplant outcomes, effect of induction before transplant, and the prognostic role of depth of response. So this is the study schema. So it was done in the UCLH, University College London Hospital, single center retrospective registry based study from 98 to 2024. 105 patients of POEMs who have taken the systemic therapy, they were included. Median age 55 years, 71% were male. 79% of the patients had impaired mobility, and the median time to diagnosis was 11 months. There are two groups, transplant cohort, non-transplant cohort. Inside the transplant cohort, again, there are two groups, no induction group, induction group. Induction group, 48% of the transplant cohort died, no induction group, 48%. They have taken directly for the transplant, male 200 was the conditioning regimen. Induction group, that is the 58% of the total transplant cohort, they have received some form of induction, out of which the most common was Lane-Dex induction, 69% of the patients. After that, they were taken for transplant. In the non-ASCT cohort, that is around 36% of the patients, Lane-Dex was the most commonly used regimen, 47%. 37% of the patients received alkylator-based regimen. Baseline characteristics, 70% of the patients were from white British ethnicity. Only 21% of the patients did not use any aids, and 79% of the patients were having some kind of morbidities. And among the disease characteristics, IgA is the most common type of M protein, 54.3%. Lambda is the most common type of light chain. It is the only type of light chain that is found in 100% of the cases. Regarding the results, if you compare the survival data of transplant versus non-transplant cohort, median OS for transplant cohort was not reached. For non-transplant cohort, it is 11.4 years. Median PFS in the transplant cohort is 10.6 years. In the non-transplant cohort, only 5.6 years. And both these data, OS and PFS, were significantly different, favoring transplant. The authors have done a remarkable job of doing landmark analysis to mitigate the immortal time bias. So what do you mean by immortal time bias? So for example, if a patient is planned for transplant, but during the waiting period, the patient dies, now automatically the patient will go into the non-transplant cohort during the analysis. Now that will make results look like the transplant is much more favorable than the non-transplant approach. Okay, so that is called as immortal time bias, and to remove that time bias, they have done the landmark analysis from 7 months after treatment initiation. So why they have taken 7 months? Because that is the median time for taking the patient for transplant. So initial 7 months they have removed from analysis, and they have compared the outcomes of transplant and non-transplant. And here also they have demonstrated that the transplant group overall survival is significantly higher. However, in the PFS, they could not show a statistically significant difference. Now this is the comparison between the transplant and non-transplant group. You can see there is a significant difference in the age. 49 years in transplant, 68 years in the non-transplant cohort. So this is very important because frailty comorbidities are more in non-transplant cohort, which they have not taken into consideration during analysis. Okay, and if you compare all the responses, whether hematological or VEGF response, everything is favorable in transplant group, and also in the improvement in the overall neuropathy limitation scale, that is also better in the transplant cohort. Now in the transplant cohort, when they compare induction versus no induction group, as you can see here, the curves are almost similar. So there are no statistically significant difference in terms of OS and PFS between induction and non-induction group. So here also the same things of hematological and VEGF response. There is significant difference between the ASCT group and the no ASCT group. However, there is no statistically significant difference between the induction and non-induction group under the ASCT cohort. Okay, so here in this table they have compared the prior induction group and the induction group. Here they could not demonstrate in terms of response, they could not demonstrate any statistically significant difference between the induction and the non-induction group. They have also analyzed some of the prognostic factors. They have shown that complete VEGF response and complete hematological response are associated with better PFS. So depth of response definitely matters. So these are the strengths, one of the larger cohorts, longer follow-up. They have also included the functional outcomes and real-world data also presented. But there are some issues, like it's a retrospective single-center study, no randomization was done. They have done immortal time bias, but age and comorbidity they have not taken into consideration. So probably Cox regression or propensity score match analysis would have been done. The authors have told that induction has to be given to symptomatic patient, or induction should be preferred in symptomatic patients. However, in their own data, they could not demonstrate that induction is showing any kind of benefit. So this is in a nutshell, whatever I have discussed. So that's all from my side. Thank you.
Thank you.
My slides are visible, sir?
Yep.
Okay. Thank you, Amia, for a nice presentation. It was an excellent presentation. So I would just announce the Journal Club and Journal Scan article for the next month, which is on 25th of June, 2026. We talk a lot about MRD, fish cytogenetics, genetic sequencing in today's era, but rarely talk about the most important parameter which is relevant for our patients is diet. So this is an interesting article published early this year from Dr. Urvi Shah from MSKCC. It's a high fiber plant-based diet in myeloma precursor disorders. The results from the NutriVention clinical trial and preclinical VKMYC model. We will be having Dr. Urvi Shah herself as the international faculty for this Journal Club article discussion. The Journal Scan article for Eagle Eye competition for next month is again related to diet. It's a recent article published in Blood Cancer Journal, Dietary Intake and the Risk of Monoclonal Gammopathy of Undetermined Significance. Results from population-based iStop-MM screening study from Iceland. I'll keep this slide on for a few seconds. Okay, and let's move on to the quiz. And I'm sure everybody must be charged up. Over to Dr. Uday, sir.
Thank you, Sumit. I'm going to share my slides. Are you able to see my slides clearly?
Yes, sir.
Thank you.
Yes.
Thank you. So with that, let's get on to the quiz for this month. But before we get on with the quiz, wherein we are going to have 5 questions on the Journal Club article and 5 questions on the Journal Scan article. There are a few announcements which I would like to make, but till the time the people can just scan the code and start joining. Anyone and everyone can join. There's no embargo on who joins. From professors to residents to MBBS graduates, anybody can join. And it's very important because now we had an AMN masterclass selection and wherein we had we had difficulty in tracing out who to be selected to be sent to Singapore, all sponsored trip. But the thing which was a tiebreaker was the participation in the journal clubs and the people who won in the journal club quizzes. So just participating in the quiz, as Sumit said, will only not give you a certificate, but also might be a ticket to Singapore or to Glasgow for this year. I wish all the members of Image a very happy Eid, and also the registration for the next year annual myeloma congress at PGI Chandigarh is open. We have the scan code here, and also the abstract submission has started. So for people who are interested in submitting their papers for the coming year annual conference, can please start submitting the papers. The PET-CT impact PET trial, which we are doing, or the study which we are doing, the survey about how the PET should be interpreted in multiple myeloma. So we have had responses, but they are not extremely good. We just had around 70 responses till now, wherein we expect more than 200 responses with 280 members in Image. So we would request all of you to scan this code and participate in this survey. It is more of an educational activity rather than anything else, wherein you will really understand the way we interpret PET on a day-to-day basis, how correct or how wrong it is. So I would request everyone to scan this QR code and participate in this particular survey. Yep. So I'm waiting for the people to join the quiz. So for those who have missed the QR code, the QR code is again flashed here. In the meantime, I would like to quickly point out few aspects of this article, Journal Scan article, which was presented. So he has spoken about, the presenter has spoken about the immortal bias and all those things. But the biggest problem in that particular article, and which also happens in most of the people from India when they write their studies together, put their studies together, the problem is the data is from 1998 to 2024. The no induction group was 1998 to 2019, and the induction group was from 14 to 24. There's a gap of 21 years. So when you see two cohorts, they have a different supportive care. The types of antibiotics which were available in 1998 are very different from now. The antifungal practices are different. The way the transplant used to be selected was different. So whenever we have data spread over such a huge period, you need to break the data. You need to show the interpretation of the first half differently, second half differently, but not put all 104 or 105 patients together. On an average, every day, you have got around 32 high impact articles in myeloma coming in. Not everything what is written there is a gospel truth. You need to look into the statistics carefully, understand what is being missed there, and then start interpreting it into your daily practice. You should not just blindly say, this article has said this and therefore we are practicing this. So that's not the right way of looking at things. So the whole reason of we having this journal club discussions and the journal scan is to make you critically understand that whatever is printed is not gospel truth. You need to read between the lines, see behind the scenes, and that's why most of the time we request the first author or the second author to come along and to present and to give us the insights, because there are many things which cannot be written or printed there. Okay, so with that, we have around 10 people who have joined. I would request more to join as we go on with the quiz, but without wasting further time, welcome back, Arun. After a long time, we are seeing you on board. Okay, so the first question, the translocation 1114 in multiple myeloma results in overexpression of cyclin D1 with which partner? So I've given 4 partners. So among these, juxtaposition to which partner leads to overexpression of cyclin D1? Yes. So I thought many would write BCL, but it's not BCL6. It would have been BCL2 otherwise. Then there is, but the overexpression of cyclin D1 is because of juxtaposition of CCND1 with IGH. It has got some connotation, which I'm going to convey while we progress with the further questions. Now, going on to the second question, which of the following best characterizes the anti-apoptotic dependency that makes translocation 1114 uniquely targetable? Okay, that's absolutely a right answer. So the concept is translocation 1114 positive myeloma cells are characterized by high BCL2 expression and relatively low MCL1 expression. So MCL1 is low, the opposite of most other myeloma subtypes, wherein they are all MCL1 dependent, whereas translocation 1114 is BCL2 dependent. So the pharmacological rationale for giving venetoclax in such patients, and which has demonstrated that high response rates, specifically in translocation 1114 positive relapsed refractory myeloma, including those who are MRD negative, in combination with DARA and DEXA, leads to a better response. So MCL1 is the other way around, and I'm happy that all of the people have answered it correct. So let's go on to the next question. Sustained MRD negativity, as defined in current multiple myeloma trials, requires which of the following? This was discussed by our international expert in great detail, and that was what was pointed out by Velu sir also. Wonderful. So you all have been very attentive during the session. So Dr. Gayatri had very clearly mentioned that sustained MRD is defined as 2 consecutive MRD negative results at a specific threshold. Please understand the threshold is also important. It used to be previously 10 to the power of -5. In fact, the Blood article also talks about 10 to the power of -5, but now we are moving to 10 to the power of -6. So that's what is going to come up in the next guidelines, which are being written in November this year. So, and they should be separated at least 12 months apart with no intervening positive results. You cannot say, I had one at 1 year gap, 2 results at 1 year gap, which are negative, but I had one more result, which was positive in between. That is not acceptable. So we should have no results in between positive, even if somebody has subjected them to a MRD in between. Now, this endpoint has been shown to be a strong predictor of PFS than the single time point MRD negativity, particularly in the context of quad inductions and transplants. The single point MRD negativity may reflect a transient suppression, whereas sustained MRD negativity indicates that there is a durable disease control. In fact, all of you need to understand this concept very thoroughly, because the IMWG is coming up with cure definition, and the cure definition rotates around sustained MRD negativity. Okay, let's go on to the next question. A 60-year-old patient with a newly diagnosed multiple myeloma confirmed translocation 1114 receives Dara-VRD induction. Bone marrow after 4 cycles shows MRD positivity at 10 to the power of -5 by NGS. He is fit for transplant. What is the most appropriate next step after you have heard today's Journal Club article? Excellent. So all of you have got it bang on. I don't need to explain it further because it was explained beautifully in the Journal Club, both by the presenter and by our national and international expert. So you need not bother with post-induction MRD positivity in translocation 11-14. And conceptually, this is because BCL2 dependency reflects a CLL type of phenotype. And therefore, in those patients, upfront MRD negativity might not matter. There can be a catcher. There can be, as Sumit also brought out, a melphalan can act beautifully in giving them MRD negativity in a period of time. So they can be taken up for transplant and you need not give them additional chemotherapy. Okay, in a multivariate analysis from recent quad ASCT cohort data, which combination of factors was independently associated with reduced risk of progression or death in NDMM? Again, this is based on what we discussed today. This is just to summarize. Wonderful. All of you have got it right. I don't need to discuss it further. So good. This is a take-home message, and we finish off with the first 5 questions of our discussion today of what we were discussing. So now let's move on to the second part, which is poems. So we have a 52-year-old male presents with sensorimotor neuropathy, hepatosplenomegaly, hypothyroidism, IgA lambda paraprotein, hyperpigmented skin thickening. Serum VEGF is markedly elevated. Now, out of all this, which is a mandatory major criteria for calling this patient as a POEMS syndrome? Angela Dispenziari had given the diagnostic criteria way back in 2003 and updated it in 2019, and they still stand true on today's date as far as POEMS is concerned. So please understand, the acronym of POEMS can mislead. Not all the features need to be present. The diagnosis generally requires both mandatory major criteria, which happens to be polyneuropathy, and the second thing is clonal plasma cell disorders. I've not given a clonal plasma cell disorder here. So polyneuropathy is given here. So 45% I've got you right. Plus any one of the other major criteria, which could be a Castleman, sclerotic bone lesion, or elevated VEGF, and one minor criteria. So in this particular situation, polyneuropathy happens to be the correct answer. Okay, in the POEMS syndrome, the clonal plasma cell population shares a key immunophenotypic feature that distinguishes it from multiple myeloma. Can you please underline what is that best characterizes the vast majority of POEMS patients from the options given below? Very good. Most of you have got it right. Please understand, lambda light chain restriction is almost universal in POEMS syndrome. There's a paper by Tompkins et al., which shows that 100% of the patients had lambda restriction. IgA and IgG isotypes predominate when compared to others. Now, this contrasts with multiple myeloma, which has near equal kappa lambda distribution. So they are approximately 1:1 or 2:1 of kappa. In Indian data, we have 1:1. The lambda restriction is so characteristic in POEMS that if you find a kappa, please reconsider your diagnosis, or it is a case report. Tumor burden is typically extremely low in these patients, and unlike myeloma where they have a high burden, which is quite common, Now, when I said mid 88 is meant for Waldenström's, not for poems. Okay. So, lambda is the right answer, which most of you have got it correct. Let's go on to the next question. A 48-year-old woman with Poems syndrome achieves hematological PR following transplant. Her VEGF at 6 months post-transplant is 1820, which is almost 2 times of that of the reference value. She is clinically stable. What is the most appropriate interpretation and the next step of action? What would you do next? Unfortunately, most of you are wrong. So the correct answer is you actually are looking for a complete VEGF response. Now, CR-VEGF is the new term which is used in Poems. It is defined as normalization of serum VEGF, and it is the strongest independent factor or a predictor for PFS in Poems syndrome. Now, this has not been looked by one person, that is Tompkins et al., who has the highest data or the largest data, but also by Owada et al., who published the same in Blood. So, universally, it is now considered that failure to achieve CR-VEGF identifies patients who are at high relapse risk. These warrant heightened surveillance. So, VEGF should be trended at regular intervals post-transplant. The whole reason of asking this question is to drive home the point that you monitor your Poems patients by VEGF values. You just don't monitor them clinically, which we used to do most of the times in our scenarios. But now with VEGF test being very easily available, so that should be the way you should be monitoring. A rising VEGF, even before clinical progression, is an early warning of relapse. Some people said sclerotic regions are a source of VEGF, but now this published information, though they therapeutically aim to normalize it, but it has not really seen that it has got a good PFS or a OS correlation. So the answer is, whenever failure to achieve complete VEGF, please consider that the patient is going to relapse, intensify your therapy, and consider salvage if it is persistently rising. A 61-year-old newly diagnosed Poems with painful neuropathy, bilateral pedal edema, mild ascites, and creatinine of 180 micromoles per liter. ECOG is 3, no significant cardiac or respiratory comorbidity. His hematologist plans for a transplant. What do you think is the next immediate management? (180 micromoles of creatinine means that the patient has got renal dysfunction, about 2. Okay, again, 40% of you have got it right. Please understand, induction therapy of RD or equivalent is indicated in this case. The reason being, if you see carefully, the patient has got presence of capillary leak phenomena. Now, how is it manifested? You have an edema, you have ascites. Now, the patient has also got significant neuropathy causing a PS of around 3. The renal impairment, which is there, generally represents in this particular scenario a Poems related comorbidity. So that itself increases the risk of ASCT related complication. So the induction aims to reverse these manifestations. Might not be the neuropathy component of it, though it might settle down, but it not disappear totally. But the induction aims to reverse these manifestations and improve the PS and the organ function before the patient is taken up for high dose therapy. Now, conventionally, we have been taught that amyloidosis and Poems should be taken up upfront for transplant, but in the presence of capillary leak phenomena and organ dysfunction, which is leading to a fall in performance status, you give some induction therapy, and the best induction therapy happens to be RD in these patients. So lenalidomide backbone is very important, and you go ahead and treat such patients. Now, people can argue, why not bortezomib based? Now, when I'm saying the patient has got a painful neuropathy, so the neuropathy can get worsened with bortezomib, not with lenalidomide, as much with bortezomib. Therefore, Len remains to be a better agent in this given scenario. Otherwise, if the painful neuropathy was not there in this equation, even a VD would have been a okay, or a VRD light would have been a okay regimen. Okay. Coming to the last question, I think the overall neuropathy limitation scale, ONLS. This was shown by the presenter. That's one of the way to track the functional neurological outcomes in POEMS syndrome. So, following successful transplant with complete VEGF response and a hematological response, which pattern of neurological recovery best represents the expected clinical course in an individual? A person who presented upfront with neuropathy, like in the previous case, so what would be the post-transplant scenario? Because many of the patients, they are worried about the neuropathy more than the underlying disorder. Wonderful. So most of you have got it right. So the answer remains to be partial gradual improvement over 12 to 24 months. So partial but meaningful neurological improvement is the realistic expectation after transplant. We can never say a POEMS patient that we are doing transplant and you will have a complete neurological recovery. That does not happen. So the median ONLS improvement is around 5 to 6, the scoring that they gave, from pre-treatment to 2 months post-transplant. So there is generally improvement by 3 or 4 points. So considering that, please never ever give a counseling of a complete recovery. Neither do a negative counseling, kuch nahi fayda hoga. So it is a partial gradual improvement which occurs by 12 to 14 months, 12 to 24 months, and there will be some amount of residual deficits. So I think that was the last question that I had here as far as this is concerned. And with that, let's move on to the thing. So Dr. Saurabh Pandey has got the highest number of correct answers, and that too in a good time record of 3 minutes 17 seconds. So excellent. Heartiest congratulations to Dr. Saurabh. And the toughest question that most of you felt, okay, was the one which was based on VEGF. So where you all were thinking that it should be a normal response, but it should be a VEGF based response. Otherwise, you need to intensify the therapy. So that's where it is. And with this, I would like to stop the presentation and hand it over back to Sumit. Thank you, Sumit.
Thank you, sir. We've already announced the articles for the next month. I request Hari sir to give the vote of thanks.
Thank you. As always, we all agree that we had a wonderful journal club and discussion, healthy discussion. And as always, Uday was perfect in his teaching capabilities. And thank you, Uday, for that. It was I too enjoyed the whole exercise considerably. And special thanks to Gayatri for being with us. And thank you for all the discussion and inputs. And again, congratulations on a wonderful paper. And with that, we have this meeting every the last Thursday of every month. We would be very happy for all of us to join us for the meeting again next week. And again, our efforts should be to get more of the postgraduates into this meeting as we go along. And if there are any other announcements, thank one here who have participated in the meeting and all the participants also. And we look forward to further improving this exercise in the future. And thank you all. I hand it over back to Sumit if there are any other announcements.
No announcements, sir. That's it for the day. Thank you.
Thank you. Thank you. Thank you.
Thank you. Thank you.
Jai Hind, sir.
Thank you, sir.
Jai
Thank you. Thank you.